السلام عليكم. اليوم respiratory system examination. Today respiratory system examination. Before you start any examination, we have introduction. Okay, patient privacy, washing your hand, introduce yourself, take permission, and so on. This is general for all type of examination. Concerning respiratory system examination, general observation for your patient in form of breathing, wheezing, voice, mental status, breathing, distress, and so on. This is general observation. Then start by hand, finger clubbing. Look or search for finger clubbing and remembers all other causes of finger clubbing. Okay? Concerning respiratory and other system. Okay? Then look for nails color, discoloration of the nails, wasting of the small muscles of the hand, Bankos tumor, which concerning Horner syndrome. Okay, also concerning Horner syndrome. Pulse, look for do pulse, tachycardia, and so on. Searching for pulses paradoxes in severe asthma. Therefore, you have to check for pulse. Okay, this hand finish. Then came to the face. In the face, we have to look for Horner syndrome, central cyanosis, pursed lips, if the lip pursed or not in case of severe COPD. Neck. In the neck, searching for GVP. Causes of raised GVP in respiration. In form of core pulmonary, raise intrathoracic pressure in case of tension pneumothorax and acute severe asthma, massive pulmonary embolism, and superior vena cava obstruction. All these causes can lead to raise GVP. After GVP, look for lymph node, look for accessory muscles, use of accessory muscles of respiration like sternocleidomastoid and scalenus muscles and so on. Okay, then examination of the chest. We finish hand, face, neck, chest. We want to examine the chest. Remember, in examination of the chest, you have to remember two main things, which is during palpation or before you start palpation, you have to check for the pain. Ask the patient for the pain. And remember, in the chest examination, inspection, palpation, percussion, auscultation, all this you do in front or for the chest, you have to do it for the back of the patient. Okay? Let us to start by inspection. Inspect your patient respiratory rate. It is high or low respiratory rate, type of your respiration, it is thoraco-abdominal or abdominal thorax, and so on. Shape of the chest. This shape of the chest could be a parallel chest, it could be pectus excavatum, and so on. The shape of the chest, we finish prominent vein. Look if there is prominent vein or not. Movement of the chest, it is symmetrical or not. There is diminish in one side or not. Look for this important point. And then palpation, palpate for trachea. It is in a normal side or not. Look for patient that deviates the trachea towards the side of the lesion and away from the side of the lesion. You have to search for these causes. Okay, tracheal tach and so on. Position of the apex, position, the apex speed position. It is in a normal side or it is abnormal displaced, okay, or not palpable. Chest expansion, reduce or increase, reduce expansion on one side or in bilateral side. There is causes that reduce the chest expansion in one side and other causes in both sides. Tactile vocal firmness increase and decrease due to what? Okay, percussion. You have to percuss looking for resonance, hyperresonance, impaired percussion, not fibrosis, dullness, stony dullness, liver dullness, or tidal percussion. Okay, sometimes you have to look for cardiac dullness. Auscultation, breathing sound, normal or not. in form of intensity, normal or increase or diminish, diminish in intensity of breathing sound. Quality for vesicular or bronchial breathing. It is vesicular or bronchial breathing. Okay. Added sound for wheeze and crackle and pleural rub. Vocal resonance, degrees increase, agophony, whispering, pictoronecry. You have to look for all this and do summary for your examination and do all this for the back of the patient. Okay. And at the end, thank you very much till we see you. Thank you. السلام عليكم. الليلة هنتكلم عن cardiovascular system examination. Before we start the cardiovascular system examination, make sure that you make the privacy of the patient and the patient is comfort and the table in 45 degree and so on and in the right side of the patient. This is the first. Okay. Then start by inspection. Inspect your patient. Inspection, general appearance of your patient, patient well, unwell, distress, and so on. Look for the hand for stigmata of infective endocarditis, finger clubbing, splinter hemorrhage, and osler node and genuine lesion. Then you can check tobacco stain and tremor. Examining the pulse, look for rhythm before rate. Start rhythm. Okay, start the rhythm before rate. Rhythm occasionally regular. Okay, sorry, occasionally irregular, regular, irregular, irregular, irregular sinus rhythm. The rate could be bradycardia, tachycardia, and so on. Look for the volume, large volume, small volume, character of the pulse, which is not fully important as a student. Look for synchronicity, look for radiofemoral delay, or do it peripheral pulsation at the end. Then check the blood pressure. Come to the face, examination of the face, look for exanthelasma and cornea for aqueous nails and pillar and central cyanosis, Muller flush and fundoscopy by ophthalmoscope to look for other sign of infective endocarditis like rosy spot and looking for hypertensive retinopathy and diabetic retinopathy. Then come to the neck. In the neck, you have to check for GVP, carotid pulsation. When you finish the GVP, you come to precardium. You want to see the precardium, the patient exposed. In inspection, you have chest deformity in form of pectus excavatum and carinatum, scars and visible pulsation and prominent vein. If you have prominent vein, you have to look for it. Then palpation. Start by apex speed. Apex speed could be normal apical impulse or displaced apex or impalpable or tapping or heaving. Or it could be double apical pulsation like in hypertrophic obstructive cardiomyopathy. Okay, left parasternal heave, second heart sound and thrill. You finish the palpation. Come to auscultation. Heart sound, first heart sound, second heart sound, if there is third heart sound or fourth heart sound. Added sound in form of open snaps in mitral stenosis or ejection, systolic click in early systole just after the S1. It does not occur if the valve is calcified. Mid-systolic click and pericardial friction. All this is added sound. If it is present you have to look for it. نفتشها يعني. تمام. في الميرمر عندنا حاجات معينة هنشوفها. التايمينج بتاع الميرمر والكاركتر بتاعت الميرمر والبيتش والintensity of the murmur, location and radiation, and if this murmur affected by respiration or this murmur affected by postures. Okay. You have to mention it all. Okay. Then after you finish the auscultation for lung phases, for crackle, pulmonary edema, examination of the abdomen for hepatomegaly and ascites, lower limb and sacral edema. Then you have to make summary for your examination, and this is the end of cardiovascular examination. إلى أن نلتقيكم في حلقات قادمة. السلام عليكم.